Hi, folks. Welcome back to Einstein's Eyes. We're glad to have you. I'm Carl Rosen, oculoplastics and neuroophthalmology, fellowship trained in Anchorage, Alaska at Ophthalmic Associates. This is my co-resident partner, friend. We trained at Einstein together, Jon. Jon?
Nice to see everybody. Again, hence Einstein Eyes, since we both worked at Albert Einstein. And I'm very excited to hear Carl today talk about something within his specialty.
Thanks, Jon. So today our topic is multiple sclerosis. Going to give a high-level view, the point of view from an ophthalmologist or neuro-ophthalmologist perspective. What do we think about? What's important? What's not? How do we diagnose? How do we treat? And how a patient should view this and think about this disease. So really, a patient typically is 30-year-old woman, walks into your office and says she has blurred vision. And about half the folks who have MS will present with something called optic neuritis, or an inflammation of the optic nerve, and they'll have blurred vision. And the blurred vision can be in the center, it could be up, it could be down. All they know is something's not right and it's disturbing. And they also have pain when they move their eye back and forth. Now, that's the most typical presentation, and our spidey sense should be up. We should be thinking about it. And I'm going to talk about how we move forward, but there's a couple other things that we also question. One is, do you have double vision? And it could be vertical double vision, horizontal double vision. It could be at near or far. It could be oblique. Do you have nystagmus, which is a jiggling eyes? That's also another tip-off, usually from the brainstem. That's where it localizes. And then lastly, we also look for something called uveitis or iritis. And with MS, you can get this thing called pars planitis, where an ophthalmologist needs to look inside the eye for that particular type of inflammation. So when we have this woman who walks in, typically, it could be a man too, we do the exam, we get usually an MRI, and we look for something that is like this. So here's an image. You have the ventricular system here. Here's the front part. Here's the frontal cortex. Here's the occipital cortex. This is called plaques. And if we see a big burden or a big load of these, we get more concerned. And we also work in conjunction with a neurologist. Now, sometimes we'll get a lumbar puncture. Neurology will sometimes do something called evoked potential tests. We do blood tests looking for certain markers and proteins and things called immunoglobulin. And then we also talk about treatment, if in fact we believe you have the diagnosis. And I'll ask a neurologist to help me make that diagnosis. I'll usually refer to a neurologist for that diagnosis to be made. And this stuff called disease-modifying therapies, which I'll talk about in a second. We also use corticosteroids, which is the mainstay, and that can be something called methylprednisolone or solumedrol. Usually it's infused in your vein at an infusion center. There's symptomatic treatments with stuff called baclofen if you have spasticity. There's physical therapy, there's lifestyle changes. Stress is a huge element in this, and you gotta modify or alter your stress levels. That really helps. So when I talk about disease modifying therapy, I'm talking about, there's three types. There's injectables, there's orals, and there's infusions. And the injectables are things like Avonex, Betaseron, Rebif, and Copaxone. These are older drugs, and really folks don't use that much anymore, though I can't say for that completely, but it's kind of like you're driving a Pinto when you could be driving a Camry. And that the Camry would be stuff like Gilenya, Tecfidera, Aubagio. These are oral drugs. They all have side effects, but it's certainly much more convenient to take a pill than to take an injection. Infused drugs, where you go to an infusion center, can be stuff like Tisabri, Ocrevus, or Lemtrada. I'm not going to dive into that. I will say Tisabri is a super interesting drug. It has what I consider to be the best efficacy, but it also comes with potential complications and side effects, particularly a thing called PML, or progressive multifocal leukoencephalopathy, that's related to a virus that lives inside us, usually in the kidneys. And your neurologist usually will monitor those JC virus levels. But really, treatment is personalized. We like to reduce remissions, and most forms of MS are called relapsing remitting MS. There is this thing called primary or secondary progressive. That's rarer. Most are relapsing remitting, where you'll have an event and then you'll have a long period of time where you don't. Pregnancy seems to protect you, but it's a real interesting disease that can be difficult to diagnose for some, because in the beginning stages where you don't have a diagnosis, you might just have pain or incontinence. You might not present with a classical blurred vision. And that makes it really tough, because people don't want to label you with MS unless we really are sure. Now, having said all that, Jon, from your perspective as a general and corneal specialist out in New Jersey, what do you do?
So I would just point out a couple of things. I think that was wonderful. I mean, great. I mean, I learned a lot from that. I would point out, diagnosis-wise, what I've seen is that it's very important to not only get a head MRI, which is great, but a neck MRI, because sometimes you'll see the white lesions on the neck or the spine, but not in the head.
Good point.
And then other things in terms of diagnosis. I mean, I've seen this as young as I agree. The classic person is that 30-year-old woman, but I've seen it in young men. I've seen it in older people now. I mean, 50s and 60s, where they presented for the first time. Maybe they had it, but they never got clinical. I guess my feeling with MS, and correct me if you think I'm wrong, is that I feel like it's more than one disease. I just feel like because I have so many patients that have had MS for 20, 30, 40 years at this point, not 40 years, but 30 years, where they've really been relatively mild. It hasn't impacted their life. And I have other people where they've really had significant disability from it. So it's hard when you get labeled with that diagnosis. What's your future? I would tell you that there's a spectrum, and it's really hard to know how severe it's going to affect you. But I agree with Carl, doing all those things proactively and also modifying your lifestyle can make a big difference.
Yeah.
And I think the last part for me is the diagnosis. Yeah, I mean, as an eye doctor, I agree with Carl. I mean, he came up with the double vision issue, the nystagmus, and the decreased vision. I don't think we normally see this in all in one person. We might see double vision in someone where they have a lesion in their brain related to that, and it's called an INO, I guess, internuclear ophthalmoplegia. And then I might see someone with optic neuritis, but I think optic neuritis is still the most common.
Right.
Yeah, but I think that was great.
No, it's great, Jon. Thanks for that those additional comments. Yeah, so MS is a spectrum, but you really want to have your radar up, and you want to listen to the patient and get a sense of what they're experiencing, because that can help ease their frustration. And that's really what we're here for. But really, compared to the 90s, Jon, when we were in training, treatments are so much better now, and they're getting better still. And I will end with this. Clinical trials, clinicaltrials.gov is a website that has the whole range of clinical trials that are out there at universities and biotech and biopharma. And if you can get involved with one of those, particularly cutting edge stuff, it could be really, really interesting. And we're always trying to collect new data to advance therapies and improve outcomes. But hey, Jon, thanks again. Thanks everybody for being here. We look forward to making our next video, but this topic is super interesting, and we'll circle back and talk more about this at a later date. But thanks, folks. We'll see you later.
Thanks.